Assalamu alaikum, I am Hussein Muhammad, third medical student at Mosul University. Our seminar today is about pneumoconiosis, supervised by Dr. Zahra Marwan. Pneumoconiosis is a group of chronic fibrosing lung diseases resulting from inhalation and exposure to organic and inorganic particulates, most commonly mineral dust, that commonly used in industrial settings. Also, chemical fume and vapor can induce pneumoconiosis. The three most common causes of mineral dust pneumoconiosis are asbestos, silica, and coal dust, as you see in the next table. In this table, we can see the agents that cause pneumoconiosis. The first agent is coal dust, that cause simple coal workers pneumoconiosis, which characterized by macules and nodules, and this can progress to complicated coal workers pneumoconiosis, also called PMF, progressive massive fibrosis, by exposure to coal mining. The second agent is silica, that cause silicosis, by exposure to sandblasting, quarrying, mining, stone cutting, foundry work, or ceramics. The third agent is asbestos, that cause asbestosis, pleural effusions, pleural plaques, or diffuse fibrosis, and also can cause mesothelioma or carcinoma of the lung and larynx, by exposure to mining, milling, and fabrication of forest ad materials, installation and removal of insulation. Pathogenesis of pneumoconiosis. The reaction of the lung to mineral dusts depends on many variables, including size, shape, solubility, and reactivity of the particles. Now I give you examples about the size of the particles. For example, particles more than 5 to 10 micrometers in diameter are unlikely to reach distal airways, while particles less than 0.5 micrometer in diameter move into and out of alveoli, often without substantial deposition and injury, because they are very small particles. But particles between 1 to 5 micrometers in diameter are the most dangerous, because they get lodged at the bifurcation of the distal airways. Coal dust is relatively inert, and large amounts must be deposited in the lungs before lung disease is clinically detectable. But silica, asbestos, and beryllium are more reactive than coal dust, resulting in fibrotic reactions at lower concentrations. Most inhaled dust is entrapped in the mucous blanket and can rapidly be removed from the lung by ciliary movement, but some of particles become impacted at alveolar duct bifurcations, where macrophages accumulate and engulf the entrapped particulates. The pulmonary alveolar macrophage is a key cellular element, and it plays an important role in the initiation and perpetuation of inflammation, lung injury, and fibrosis. Tobacco smoking worsens the effects of all inhaled mineral dusts, but more with asbestos than the other particles. Now my colleague Mustafa will continue.
Assalamu alaikum, my name is Mustafa Asum. I will talk about coal work and pneumoconiosis. Coal is a mainly carbon. Coal mine dust contains a variety of the trace metals, inorganic minerals, and crystalline silica. Worldwide dust reduction in coal mines has greatly reduced the incidence of coal dust-induced disease. Anthracite mining has been associated with a higher risk for coal worker pneumoconiosis. Pathogenesis. The spectrum of the lung findings in coal workers is wide, ranging from first asymptomatic anthracosis, in which pigment deposits without a perceptible cellular reaction. Second, simple coal worker pneumoconiosis, CWP, in which macrophages accumulate with little to no pulmonary dysfunction. Third, complicated coal worker pneumoconiosis, or also called progressive massive fibrosis, PMF, in which fibrosis is extensive and lung function is compromised. Less than 10% of all cases of simple coal worker pneumoconiosis are progressive to PMF. PMF is a generic term that applies to a confluent fibrosing reaction in the lung and can be complication of any type of pneumoconiosis. Morphology. First, pulmonary anthracosis is the most necrous pulmonary lesion in coal miners. In the left picture, we see a cross-section of the lungs in anthracosis, and in the right picture, the histopathology examination. Anthracotic pigment ordinarily is not fibrogenic, but in massive amounts, as in black lung disease in coal miners, a fibrogenic response can be elicited to produce the coal worker pneumoconiosis. See here. Second, simple coal worker pneumoconiosis. Patients have cold macules 1 to 2 mm collections of carbon-laden macrophages and a small amount of collagen fibers, and larger cold nodules, cold macules, and fibrosis scattered throughout the lung, more in the upper lobes and upper zone of the lower lobes, near the respiratory bronchioles. In due course, centrorepular emphysema may occur. Third, complicated colorectal pneumoconiosis (PMF). It is characterized by multiple dark black scars larger than 2 cm and sometimes up to 10 cm in greatest diameter that consist of dense collagen and pigment. Clinical features. Colorectal pneumoconiosis usually is a benign disease that produces a little decrement in lung function, but in those of PMF develops, there is an increasing pulmonary dysfunction, pulmonary hypertension, and cold pulmonale. In this picture we see complicated colorectal pneumoconiosis in X-ray. There is no increased frequency of lung carcinoma in coal miners. These features that distinguish colorectal pneumoconiosis from both silica and asbestosis exposure. Now my colleague Roa will continue.
Assalamu alaikum. I am Roa Marwan and I will talk about silicosis. Silicosis is currently the most prevalent chronic occupational disease in the world, mostly in occupational settings. It is caused by inhalation of crystalline silica. Silica occurs in both crystalline and amorphous forms, but crystalline forms, including quartz, cristobalate, and tridamite, are the most toxic and fibrogenic. Quartz is most implicated in silicosis. As we see in these pictures, the types of silica, crystalline and amorphous forms. Pathogenesis. After inhalation of crystalline silica, these particles interact with epithelial cells and macrophages, lead to release of mediators, including interleukin-1, tumor necrotic factor, fibronectin, lipid mediators, oxygen-derived free radicals, and fibrogenic cytokinase, and eventually lead to fibrosis. Now, we will watch a video explaining what are the effects of the silica and other particles on the lung.
Silica. It's one of the most common substances on Earth. It can be found in materials like sand and rock, and building products like concrete and brick. When a worker cuts, grinds, or drills materials that contain silica, dangerous crystalline silica dust is released into the air. As the worker breathes, silica crystals flow into his mouth and nose and down the air passages deep into the lungs. The tiny crystals enter the small, fragile air sacs, where oxygen is absorbed into the blood. Immune system cells, called macrophages, engulf and try to dissolve the crystals, but they are unable to. Over time, more and more crystals build up inside the macrophage cells. The macrophages carry the silica into the walls of the lung, where they die. Scar tissue forms around the dead cells and spreads as more cells die. This damage can continue even after the exposure to silica stops. Eventually, so much scar tissue forms that the lungs can no longer function. For information on how to protect yourself from silica exposure.
Morphology. In cross-section, silicotic nodules in their early stage are tiny, palpable, discrete, and pale to black if coal dust is present, and it's in the upper zones of the lungs as we see in this picture. Microscopically, a silicotic nodule within lung parenchyma is seen here. It demonstrates concentrically arranged hyalinized collagen fibers in word appearance surrounding an amorphous center, and there is a minimal inflammatory reaction. The word appearance of the collagen fiber is quite distinctive for silicosis, and as the disease progresses, individual nodule may coalesce into hard, collagenous scar with eventual progression to progressive massive fibrosis. Fibrotic lesion also may occur in hilar lymph node and the pleura, not only lung parenchyma. Examination of the nodules can be done by polarized light microscope, as we see in this picture the bright white silica crystals of varying sizes. Clinical features of silicosis. Silicosis usually is detected in asymptomatic workers on routine chest radiographs. As we see in these pictures of chest X-ray, the difference between normal, simple silicosis and progressive massive fibrosis. Most patients don't develop shortness of breath until late in the course, after progressive massive fibrosis is present. Also, patients with progressive massive fibrosis develop pulmonary hypertension and pulmonale. The disease is slowly progressive. Silicosis is associated with an increased susceptibility to tuberculosis, and it depresses cell-mediated immunity, in which crystalline silica inhibit the ability of pulmonary macrophage to kill mycobacteria. Most studies suggest that silica exposure is associated with some increase in risk of lung cancer. Now, my colleague Hind will continue.
Assalamu alaikum. I'm Hind Ziad and I will talk about asbestosis and asbestos-related diseases. Asbestos is a family of crystalline hydrated silicates with fibrous geometry. Asbestos exposure is linked with 6 disease processes. First, parenchymal interstitial fibrosis, which means asbestosis, and localized fibrous plugs or rarely diffuse fibrosis in the pleura. And also we have pleural effusions, lung carcinoma, malignant pleural and peritoneal mesothelioma, and also the laryngeal carcinoma. Now, in this slide, we have 2 pictures. In the left picture, we see the normal lungs, but on the right picture, we see lungs with asbestos-related disease. As we can see the pleural plug, lung cancer, scarred lung tissue, and also we can see mesothelioma or plugs on diaphragm due to asbestosis. Now we talk about the pathogenesis of asbestosis. After inhalation of asbestos, these particles will interact with epithelial cells, macrophages, and penetrate the alveoli, which release of mediators including interleukin-1, tumor necrosis factor, fibronectin, lipid mediators, oxygen-derived free radicals, and also fibrogenic cytokines, which lead to interstitial fibrosis, and also act as a tumor initiator and promoter, which lead to carcinogenesis. The morphology. Asbestosis is marked by diffuse pulmonary interstitial fibrosis, characterized by the presence of asbestos bodies, which are seen as golden brown, fusiform or beaded roots with a translucent center. They consist of asbestos fibers coated with an iron-containing proteinaceous material. In contrast with cold worker pneumoconiosis and silicosis, the asbestosis begins in the lower lobes and subpleurally, spreading to the middle and upper lobes of the lungs as the fibrosis progresses. The contraction of fibrous tissue distorts the normal architecture, creating enlarged air spaces enclosed within thick fibrous walls. Eventually, the affected regions become honeycombed. In the upper picture, this is the causative agent for asbestosis, a long, thin asbestos fiber. And in the lower picture, we see a high-powered detail of an asbestos body. In this picture, we see a markedly thickened visceral pleura covers the lateral and diaphragmatic surface of the lung. Also, severe interstitial fibrosis diffusely affecting the lower lobe of the lung, causing adhesions between the lungs and the chest wall. The pleural plugs are the most common manifestation of asbestos exposure, and this picture shows microscopically. The fibrous pleural plug is composed of dense layers of collagen, often containing calcium, and they develop most frequently on the anterior and posterolateral aspects of the parietal pleura and over the domes of the diaphragm. Clinical features. The clinical findings in asbestosis are progressively worsening dyspnea, appears from 10 to 20 years after exposure. It's usually accompanied by a cough and the production of sputum. The disease may remain static or progress to congestive heart failure, cor pulmonale, and death. Pleural plugs are usually asymptomatic and are detected on radiographs as circumscribed densities. Both lung carcinoma and malignant mesothelioma develop in workers exposed to asbestos. Cigarette smoking increases the risk for lung cancer in the setting of asbestos exposure. Furthermore, even family members of workers exposed to asbestos are at increased risk for cancer. And now, my colleague Hussein will explain the summary of our seminar.
The summary of our seminar. As we said previously in our seminar about the most common causes of pneumoconiosis, the first cause is about coal dusts that cause lesions ranging from asymptomatic anthracosis to simple coal worker pneumoconiosis. The last lesion concentrates more in the upper lobes and upper zone of lower lobes of the lungs and may lead to centrilobular emphysema that cause dilated respiratory bronchioles. The second cause is about silica particles that cause silicosis, which is the most common pneumoconiosis in the world, that lead to asymptomatic silicotic nodules, which appear mainly in the upper zones of the lungs. Now, the third cause is about asbestos particles that cause asbestosis, which is a diffuse pulmonary interstitial fibrosis. This disease begins in the lower lobes and subpleurally, in contrast to coal worker pneumoconiosis and silicosis. And also, asbestos exposure is linked with many other diseases that mentioned previously. As you see in all this picture, the pulmonary alveolar macrophage is a key cellular element, and it plays an important role in the initiation and perpetuation of inflammation, lung injury, and fibrosis. And lastly, we should know that any type of these three diseases can progress with time to progressive massive fibrosis. And lastly, thank you very much for watching and listening.